Thank you to the organizers for inviting me to this meeting. I'm sorry that I'm not there in person, specifically because right now the high where I am in Iowa is about 10 degrees Fahrenheit. So much more comfortable in Melbourne than it is here. So I'm going to be talking about US vaccine policy, which is a subject that seems to change almost on a weekly basis, but I'll tell you what I know now. So first of all, a declaration of my participation in vaccine decisions. I'm a member of the FDA VRBPAC, Vaccines and Related Biological Products Advisory Committee. I'm a member of the COVID-19 Working Group Advisory Committee of the ACIP, which is not to be confused with the parental ACIP, the Advisory Committee on Immunization Practices, which is, both of these committees are through the CDC. And the third committee I'm on is the WHO Technical Advisory Group on COVID-19 vaccine composition. So I participate at all levels in vaccine selection. So how did vaccines become so controversial in the US and elsewhere in the world? So vaccination in the US and elsewhere has always had opponents, mostly for religious or medical reasons. And as countries have become more accepting of these kinds of exemptions, more people ask for them, with the result that levels of immunization have gone down. And part of this is because societal memory of diseases like polio and measles have increased vaccine hesitancy, lack of societal memory has increased vaccine hesitancy. Societal memory has minimized it. So when I was growing up, there were children walking around with crutches who had just had polio in the last few years. And children were still dying of measles. So in the US, this has been particularly an issue because Americans have long had beliefs in the right to personal choice based on societal and religious factors, among others. And these beliefs came into conflict with public health mandates regarding mitigation procedures. So there was a lot of discussion in this country when people wanted to have church services, for example, early in the pandemic, and it was noted that that was a way for the virus to spread. So some things were banned, and a lot of certain groups then opposed this strongly. And so then there were lockdowns, which I think every country has dealt with during at one time or another during the pandemic. And then one thing that became a prominent problem was school closures. There was school closures that were quite lengthy in parts of the US. This clearly hurt children who came from families without resources. They fell behind. And we know now, and even then, the children were not the major source of transmitted viruses. So these all led to skepticism about public health authorities in general, and led to skepticism about vaccines. And the other thing that happened is both the initial SARS-CoV-2 infection and the vaccine seemed to have sequelae. So early in the pandemic, there were many reports of previously healthy young men and women who had consequences of being infected with SARS-CoV-2. They had long COVID. So some of them had brain fog, some of them had heart problems, there were seizures. There was a lot of really bad things that happened during the acute infection, and then some of them carried over to long COVID. And one of the things that happened is long COVID never really went away. So for some people, so for a lot of people, it lasted a few months and then disappeared. But there is still sequelae from the effects of the pandemic. I know personally of people who had anosmia, who lost a sense of smell, and 2 years later, they mostly recovered, but they didn't completely recover. So they have very minor defects. And one of the things, of course, is it's really hard to remember for most of us what things smelled like or looked like several years ago, or even months ago, because what you have now is your own reality. So there was definitely some of these things were long lasting. Then there's a whole question about the vaccine, whether that has sequelae too. It's been very hard, except for myocarditis in young men, really hard to pin this down. But people who don't believe in vaccines think there's lots of sequelae and that these need to be handled differently than they are being handled. I'll discuss that towards the end of this little talk. So there's discussions of long COVID and post-COVID vaccine syndrome became fused, leading to more vaccine misinformation and skepticism. The general result was lost distrust of public health authorities by some groups, and this was reinforced by the recent election in the US of Donald Trump and his appointment of Robert Kennedy, who was a longtime vaccine skeptic, as the Secretary of Health and Human Services. So how are vaccines made? I think most of the people in this room know this, but I'll just go over this briefly. So the first thing that happens is the World Health Organization convenes experts from multiple countries. Meetings are held in November, December, and then April, May, and there's maybe 5 to 10 meetings at each of these sessions. During these meetings, we discuss strain evolution, we get information about vaccine-derived immune responses monitored by academic centers and drug manufacturers. We get preclinical data, and we make a final recommendation for strain selection. And this has become a little harder in the last year or so because the number of sequences that we're actually getting to as our databases is decreased in number. So before we had lots and lots, now we know what strains are circulating, but we don't have the fine details that we used to have before. These meetings are closed, and then individual countries then make decisions based on the WHO data. So in the US, the way this works is the VRBPAC, the FDA committee, reviews the data, same data that the WHO may have had, but more specific for the US, and then makes strain recommendations. The ACIP then meets to discuss policy. So who should receive vaccine, and how can we be sure that all groups can receive this equally? Early in the pandemic, not early, even still, the ACIP is informed by the committee that I'm a member of, the COVID-19 working group, which reviews all the data and helps the ACIP make recommendations. We held these meetings once a week from 2020 to 2025. And all these issues are discussed over and over again. Efficacy, we have the manufacturers come in, and equity was a big deal because in the beginning of the pandemic, there were certain populations in the US, such as African Americans, who were, for many reasons, historical mostly, but very skeptical of healthcare authorities. But with time, this actually switched. So now African Americans, Black Americans, became more accepting of the vaccine, and the groups that actually didn't have vaccine equity tended to be white Americans, particularly those who were supporters of Donald Trump. So one huge thing that's changed in the last bits of time is the ACIP sets vaccine policy, not the VRBPAC, but recently there's been policies made by either VRBPAC, the FDA committee, or by Kennedy himself. And this is really a change on the way things have been done. So, this means that this orderly process is no longer in place. So next step after strain selection is who should receive the SARS-CoV-2 vaccine. And this would normally be done by the ACIP. And so just to go over what the recommendations would have been before September 2025 in the United States, there's general agreement, like there is in the rest of the world, that those over 65 or 75 years old are those especially susceptible to severe disease, those who are immunocompromised, those over 50 years of age with comorbidities should receive a vaccine booster. Now, in the US, this was a change in the US because before then, the US had recommended universal vaccination for anyone who wanted to get the SARS-CoV-2 vaccine. And also, in addition to these groups, the people in long-term care facilities were recommended to get the vaccine. As far as I can tell, the deaths in the US that are occurring now are predominantly in elderly people who are in long-term care facilities. And those who are pregnant or likely to become pregnant were also recommended for boosting. This was partly because it was recognized that babies under the age of 6 months up to 2 years were actually more likely to get severe disease in other groups. It was pretty clear even earlier in the pandemic, once we got over the initial phase, that people who were 2 years to about 50 or 60 years either were so exposed to the virus or had antibodies and really didn't develop severe disease anymore. So the recommendation was going to be that pediatric patients should receive the primary SARS-CoV-2 vaccine series. And then another question was whether people who were in these highly susceptible groups should receive a second boost at 6 months. This was a discussion point. There's certainly very good evidence that, particularly with the mRNA vaccines, that there's a waning of immune responses, so that the antibody titers, both neutralizing or those that bind to the S protein, diminished over the few months after vaccination. So by 6 months, they were quite low. So the idea was to give a second boost to these highly susceptible groups to improve their immune responsiveness and protection against severe disease. However, I don't know of any data that actually showed that boosting improved clinical outcomes. I know it boosted antibody titers, but I don't know of clinical outcomes. There may be knowledge out there that I don't know about. Another controversial issue is whether vaccination should be offered to people who are between 50 and 60 years of age. These groups may have had slightly higher risk of more severe disease. In some countries, it's recommended that these groups not be vaccinated against SARS-CoV-2. And then those under 50 years are not recommended to be vaccinated by most regulatory authorities. This was a group that was recommended in the US prior to the present recommendations. But whether it was necessary or not is, I think, one of the issues that's not resolved. So this just shows some of the vaccine recommendations in different countries. And one can see here in Australia, 65-year-olds and older with high risk should be vaccinated. In other countries, it's 60 years and older. In Norway, it's 45 years and older. And it's clearly different, but it's all every country recognized that people who are older and at high risk needed to be vaccinated. And I should point out these recommendations were published in the New England Journal by Prasad Makary. Makary is actually the head of the FDA. So one would have thought that as of May 2026, that boosting would be fairly standardized with the rest of the world in the US. And then the same article published the lists of diseases that required extra boosting. And even in the editorial, it mentioned that this was a huge fraction of the US population, maybe a third of people. So there was really not that great elimination of the opportunity for people to get vaccines. Certainly that healthy 40-year-old was not going to be in the group that should receive the vaccine, according to the US authorities. And again, these people are from the FDA. In the past, these decisions have not been made by the FDA, but rather have been made by the CDC and its ACIP committee. And I point out here pregnancy and recent pregnancy is on this list. So what happened after Donald Trump became president and Robert Kennedy became HHS secretary? Well, nothing much happened for a couple of months, but it was really short because Trump became president in January 2025, and Kennedy became Human and Health Services Secretary, well, I think in probably February or March. And by April, or by May rather, all the members of the ACIP, the CDC's Immunization Advisory Committee, were fired. And they were fired because they were said to be biased, which in itself was a really odd designation. Some of the people, for example, who were fired were people who represented the American Academy of Pediatrics, which is the pediatric society that looks over what's best for children. And they were considered biased, I guess, because they were interested in preserving good pediatric health. I'm a pediatrician too, so I'm scratching my head why I am still allowed to be on all these committees. They were replaced with SARS-CoV-2 vaccine skeptics or people who signed the Great Barrington Declaration. The Great Barrington Declaration was very similar to what was being done in Sweden at the time, which is the idea was focused protection, which is people who are most vulnerable would be sequestered from other people, and then life would go on normally for people who were not likely to get severe disease. So this was a fine idea, but it didn't work, I don't think, in Sweden, and it didn't work in the US. So it's whether there were actually more deaths or worse outcomes with or without focused protection, I think is hard to know for sure. The second thing that happened is that the CDC staff were either fired or they quit or they were assigned to other CDC sections. One of my colleagues who was in charge of much of the SARS-CoV-2 work at the CDC was reassigned to bacterial disease. And so far, the ACIP has been most severely affected. The VRBPAC has not had changes in its composition yet. One person was removed from the panel. He was particularly knowledgeable about vaccines and particularly outspoken about the changes. But for many of us, our terms end on the end of January 2026, which is right now. We have not heard whether we're going to be replaced or we're going to be continued. I'd be surprised if we were continued, but who knows? So how did the ACIP recommendations change? Well, I mentioned some of these already. There were previously recommendations for universal vaccine in the US. Now anyone can be vaccinated, but they have to talk to their healthcare provider. This hasn't had huge effects because, in fact, when one's supposed to get a vaccine, any vaccine, one should have informed knowledge. One should know about the vaccine. So talking to a healthcare provider is a good idea. It may affect the ability in the US of pharmacists to administer vaccines, but we don't know. There was a discussion of requiring a prescription for vaccination, which would have been a big reason, would have been a major hurdle for a lot of people to get vaccinated. But this was voted down 7-6. Surprisingly, the committee voted 6-6, and the chairperson, who's a pretty well-known vaccine skeptic, voted against having a prescription. Whether for this reason or not, he's no longer on the committee and he's working elsewhere in the HHS. And then there are these statements in the vaccine information statement that say things like the SARS-CoV-2 vaccine has impurities related to the vaccine, frame shifting of the DNA, immune dysregulation, all of which are interesting research topics, but certainly not relevant for vaccine, I don't think, and certainly not helpful to patients to see this in writing. So, and there's several others that are as well. And so there were additional changes in vaccine recommendations made by either the ACIP or Kennedy through the HHS. Influenza is no longer universally recommended for all children. Rotavirus is no longer universally recommended for all infants. Hepatitis A is no longer recommended for all children. Hepatitis B is no longer recommended, and its use in newborns is now restricted to only those who have antigen E antibody positive mothers, or antigen rather, E antigen positive. RSV vaccines are not recommended. This is a little unclear since infants never got active RSV vaccines, rather they got passive antibody or their mothers were vaccinated. Meningococcal is no longer recommended. So there's a lot of changes, which many of us think are going to be bad for pediatric health. And then there's the last couple of things, my last 2 minutes here. One recommendation is that one thought is that vaccines are going to be reevaluated in placebo-controlled studies. They were originally evaluated in controlled studies. In many cases, irrelevant active controls were used. So, for example, for hepatitis A, the control was hepatitis B vaccines. So controls received the benefit for participating. And a second one is that vaccines not be administered on the same day, or at least the number decreased. This is based on the false idea that having 7 vaccines will overwhelm the immune system. As Paul Offit, who's a vaccine expert, pointed out, these 7 vaccines had less than 200 proteins. The smallpox vaccine, which we used to have, had hundreds to thousands. So consequences of the vaccine is there's confusion in the US, there's more uncertainty about vaccines in general, and there's already resurgence of diseases in the US. There's thousands of cases of measles, and there's not very many cases of polio yet, but I know there's been some. And then in the world, we have the same kind of issues. This is a child with measles. I should say this is a panel, a view of children and adults on iron lungs before the polio vaccine. This is the measles, case of measles, which is another disease, as I just mentioned. And the US has long been a model for public health measures and interventions. And the FDA's, CDC's decisions are used by other countries to help make decisions. Countries will now have to make their own decisions without FDA, CDC input. Even in the US, some states are deciding to not follow the CDC input. And I don't know how this will affect manufacturers since they depend on the US market. So what is next? And this will be the last thing I'll talk about. The panels are now focusing on biosafety and on the definition of post-SARS-CoV-2 vaccine injury and updated vaccine injury diagnostic codes, which is all good, except that the people who are having most of the opinions about this are people who are skeptical about vaccines. One example is the DNA contaminants in mRNA vaccines, which is something that may or may not be important, probably is not important. And then placebo-controlled trials for vaccine updates, which will mean vaccines won't be updated. No manufacturer will ever want to change as a change from one SARS-CoV-2, for example, variant to another, doing a controlled style is ridiculous. And in the US, we have National Vaccine Injury Compensation Program. If this is rendered irrelevant, then there'll be huge problems for manufacturers again. So with that, I see that I went over, so I will stop.